Let's see about mouth breathing habit. So mouth breathing habit is mostly occur in the children. So let's see about in detail. So first, mouth breathing habit, it is defined by Sassoni, habitual respiration through the mouth instead of the nose. So that is a habitual respiration through the mouth instead of the nose. It's said by Sassoni in 1971 and merely said oronasal breathing instead of the mouth breathing in 1980. So merely said oronasal breathing instead of the mouth breathing. So Sim and Finn, they are classified mouth breathing into three types. They are obstructive, habitual and anatomical. So Sim and Finn, mouth breathing classified into three types: obstructive, habitual and anatomical. The first one is obstructive mouth breathers. So there is an increased resistance to or a complete obstruction of the normal flow of air through the nasal passages. So because of the difficulty of inspiring and expiring air through the nasal passages, the child is forced by sheer necessity to breathe through his or her mouth. So because of the difficulty of inspiring and expiring the air through the nasal passages, there is a difficulty. So it produces mouth breathing habit. So the following area of some of the cause of the nasal obstruction. So what are the causes? First one is deviated nasal septum. There is a nasal polyps and there is chronic inflammation of the nasal mucosa and localized benign tumors and congenital enlargement of nasal turbinates and allergic reaction of the nasal mucosa and obstructive adenoids. So next, moving to the second type, that is habitual mouth breather. So this is a child who continually breathe through his or her mouth by force of habit, although the abnormal obstruction has been removed. So this mouth breathing becomes a deep rooted habit that is performed unconsciously. So after we remove that cause for the mouth breathing habit, the child continue to breathe through his mouth. It is a habitual. And the third one is anatomical mouth breather. So an anatomic mouth breather is one whose lip morphologically does not permit complete closure of the mouth. So such as a patient having short upper lip. If the patient having short upper lip, they cannot close their mouth. So this is an anatomical mouth breathers. So it is the third type. So obstructive, habitual and anatomical. Next, moving on to what is the pathophysiology of mouth breathing habit. So during oral respiration, three changes in posture occur. The first one is lowering the mandible and the next one is positioning the tongue downwards and forward and the third one is tipping back of the head. So these are the three posture. So lowering of the tongue and mandible upsets the orofacial equilibrium. So there is unrestricted buccinator activity that influences the position of the teeth and also the growth of the jaw. So there is an unrestricted buccinator activity in the mouth breathing habit patients. So it influences the position of the teeth and also the growth of the jaw. That's why there is a reduced mandibular or there is a prognathic maxilla. So what are the clinical features? So there is a hypertrophic mouth breathing gingivitis. It is very important. There is hypertrophic mouth breathing gingivitis and the facial appearance of the mouth breathing child known as adenoid faces. It is very important, adenoid faces. So it has characteristics of long narrow face, narrow nose and nasal passage. Narrow nose and nasal passage and long narrow face. So there is a flaccid upper lip and dolichofacial skeletal pattern. And the next point is nose tipped superiorly and expressionless face, mask-like face and narrow maxillary arch. So there is a posterior cross bite and anterior open bite and labial flaring of the maxillary incisor, that is maxillary incisor proclined and nasal tone in voice and there is a definitely gummy smile. So these are the clinical features present in mouth breathing habits. So in gingiva, especially mouth breathers frequently present with problems like, and there is an inflamed and irritated gingival tissue. So inflamed and irritated gingival tissue in the anterior maxillary arch. So and the gingiva is hyperplastic due to the continuous exposure of the tissue to air drying. So there is a chronic gingival condition is due to decreased salivary flow to remove the debris and the bacterial overgrowth. So there is a decreased salivary flow, so it produces the heavy deposits of the plaque. So gingiva exhibits a classic rolled margin. So this picture showing the right side there is a narrow palatal arch, and the left side the profile of a mouth breather. There is tired eyes, crooked nose, receding chin and smaller airway and narrow face and bad posture. So mainly there is a crooked nose and receding chin and narrow face. These are the important clinical feature of the mouth breather. This is the profile. So there is a heavy deposits of plaque. Obviously it leads to the periodontal problem. There is the gingiva exhibit a classic rolled margin and enlarged interdental papilla. So it produces periodontal disease. It leads to interproximal bone loss with the presence of the deep pocket, and other effect include otitis media. And it is very important, palatoglossus muscle active in nose breathers. It is very important, palatoglossus muscle is active in nose breathers, and levi palatin activity is lower in nose breathers, and there is a sense of smell is dull and loss of taste is also present. What are the diagnosis? First diagnosis, observe the patient. If the mouth breathers, the lips will be apart. If nasal breather, the lip will be touching. And second one is, ask the patient to take a deep breath through the nose. So if mouth breather, no change in shape or size of the external nerves. If nasal breathers, there is a demonstrates good control of alar noses. So it is a two diagnosis. Next, the third diagnosis test is mirror test. So mirror test is also known as fog test. So mirror test is also known as fog test. The mirror has two surfaced. So the two surfaced mirror is placed on the patient upper lip. So if air condenses on a upper side of the mirror, the patient is a nasal breather. If it does sooner on the opposite side, there is a lower side, it is a patient having a mouth breather. So in the upper side there is a nasal breather. If it is the opposite side, it is a mouth breather. And the fourth one is Masler's water holding test. What is Masler's water holding test? So the patient is asked to hold the mouth full of water for a few minutes without swallowing. So if the mouth breathers used this technique, they cannot retain their water for more than 2 to 3 minutes. It is Masler's water holding test. If mouth breather cannot, if patient having mouth breathing habit, he cannot hold water in their mouth. And the fifth one is Swimmer's butterfly test. So take a few fibers of cotton and place them just below the nasal opening. On exhalation, if the fibers of the cotton flutter downwards, so we have to place the fiber of cotton on the just below the nasal opening. On exhalation, so if the fibers cotton flutter downwards, if patient having nasal breathing. If it fibers, the cotton fibers are flutter upward, so patient having mouth breathing habit. And the child should close his eyes before the cotton is held to his nostrils and mouth, so that breathing will be entirely natural and not forced as when the child is deliberately instructed to breathe through his or her nose. And the sixth one is rhinometry. Rhinometry is also known as inductive plethysmography. So the total airflow through the nose and mouth can be quantified using inductive plethysmography. And the seventh one is cephalometrics. It can be used to calculate amount of nasopharyngeal space. These are the diagnostic method for mouth breathing habit. There is a 7 methods. And the next one is resistant to nasal breathing. It is caused by hypertrophy of nasal turbinates, that is caused by allergy and climatic conditions, and deviated nasal septum with a blocking of nasal passage, and there is enlarged adenoids. So there is enlarged adenoids and hypertrophy of the nasal terminates. It is due to the allergy and climatic conditions. So in younger children, physiologically the hyperplastic adenoids are present. So the mouth breathing may be self-correcting as the child grows. So grow older, it is self-correcting because of the physiological shrinking of the adenoids. So adenoid faces is a term used to describe a particular type of facial configuration frequently associated with this habit. So adenoid faces is characterized by a long narrow face with accompanying narrow nose and nasal passages. There is a flaccid lips with the upper lip being short and dolichofacial skeletal pattern. And although most dental literature points to mouth breathing as an etiological factor of malocclusion, and the mouth breathers person holds the tongue low and forward to keep the mouth open. So the cheeks exert a force against the buccal surfaces of the maxillary posterior teeth. So it is not balanced by the presence of the tongue in the palatal area. That's why there is a narrow palatal arch. So decreases the labial support to the maxillary anterior because of the lack of tonicity in the lips. That's why there is the proclined maxillary incisor. And what is the management? The first one is identification and correction of nasal obstruction. And the second one is physical exercises. One is respiratory exercises and another one is lip exercises. And stretching and twisting of the upper lip, and mechanical, that is a oral screen. What is oral screen? It is an appliance. It will block the passage of air through the mouth and force the inspiration and expiration of air through the nares. So one should ascertain if the nasopharyngeal passage is sufficiently patent to allow for the exchange of the air. So the oral screen is a solid shield inserted in the mouth. So it rests against the labial fold. So this picture showing the one type of oral screen. So there is a hole in the oral screen. It is a modification. This is also a modification of oral screen. Let's see modifications. So this picture is lip exercise for the mouth breathers. This is also another type of oral screen. So oral screen, it is an appliance which will block the passage of air through the mouth and force the inspiration and the expiration of the air through the nares. So one should ascertain if the nasopharyngeal passage is sufficiently patent to allow for the exchange of the air. The total oral screen is a solid shield inserted in the mouth, so which rests against the labial fold and is employed to prevent mouth breathing and encourage breathing through the nose. So this is generally inserted at night before going to bed. So it is very important. Inserted at night before going to bed and worn throughout the night, so that the child is forced to breathe through the nose while asleep. So tapping the lips together at night is also described as a method of managing mouth breathers in the literature. So what are the advantages of the oral screen? The first one is it is a myofunctional appliance, and that is easy to fabricate and easy to wear, and it is a curved corresponding to the curvature of the arch, and it is made of acrylic, and it works on the principle of both force application and force elimination. Posterior crossbite, it is corrected by the utilizing the principle of the force elimination. So anterior teeth proclination is corrected by the utilization of the principle, that is force application. So force application is anterior teeth proclination, and force elimination is posterior crossbite correction. So the anterior teeth proclination can be corrected by utilizing the principle of the force application, which is possible by making the screen come in contact with the proclaim teeth. And the lip exercise are possible with oral screen, which improve the tonicity of the lips. What are the modification? The first one is, if the patient feels difficult to breathe, then multiple holes can be made that are closed one by one over the period of time. So giving the holes, it is the first modification, and the metallic ring is made and placed in the midline of the appliance, and it will help hold the oral screen. It is the Holt's modification. And the next one is double oral screen. It can given with a similar additional lingual screen. Normally there is only a palatal screen is present in the oral screen. If we give lingual screen, it is double oral screen.